Okay, so now a little bit closer look at the cognitive symptoms. So we did talk about concrete thinking already, and that basically people can't think abstractly. Everything is very kind of black and white, and they really can't interpret proverbs at all. So if you say the grass is always greener on the other side of the fence, they would not be able to say kind of what the meaning of that phrase is. They might say something very concrete, such as the other side gets more sun, so that's why the grass is more green over there, or just something that's really very concrete. They don't get the gist of what a proverb like that might mean. And again, if you ask them how they got to the hospital, they're going to say they took a bus, somebody dropped them off. Just that lack of abstract thinking. Little children have naturally demonstrate concrete thinking, but as you grow older, we all grow out of that, and we're able to think more abstractly as we go on in grammar school. Impaired memory. So short-term memory usually, and the ability to learn new things. So sometimes the nursing implication, of course, would be that we would repeat things, give them visual cues, especially when we're trying to do some teaching. They might have impaired information processing, so they might have, they can't process as quickly as you can. They might lag a little bit kind of between what you say and then their response. There sometimes is that kind of delay, just a bit of a lack of understanding of other people, of what other people are trying to tell them. And they may also, as part of that information processing issue, they may also really have difficulty screening out stimulation that is not significant. So if there's background noises or something going on down the hall, they sometimes get overly focused and overly stimulated on every little thing around them rather than on what they should be focusing on, maybe which might be taking their medication. They might be having a conversation with a nurse out in the hallway, and they can't help but responding to everything around them. So we as nurses have to keep track of if they do become overstimulated like that, and maybe lead them to a quieter place of less stimulation. And they have impaired executive functioning, so they have a lot of trouble with reasoning, like using logic, setting priorities, comparing options, placing things in logical order, planning and kind of organizing their daily lives, and kind of holding back on their inhibitions, and especially if they're having some impulses that are not very helpful. So that would mean then in their day-to-day life, they really might need a lot of help with trying to keep things organized and scheduled. Just think if you as a student had trouble with your executive functioning, you would never be able to get anywhere on time. You wouldn't be able to plan and organize all the multiple things that you have to plan and organize in order to be a successful student. So the impact on the person with schizophrenia is then they just really have trouble making appointments, doing things in a timely way, planning ahead even, and trying to think ahead and anticipate something and plan for it. They just really are not able to do that. Affective symptoms. So assessment for depression really truly is crucial because it really does go hand in hand. It is such a comorbidity. Depression, anxiety, suicide are such big comorbidities for schizophrenia. So we have to recognize that when people have depression as part of their schizophrenia, they really are truly suffering. So we need to assess that. It may herald an impending relapse, so perhaps their schizophrenia symptoms are going to become worse. It increases the risk of substance abuse because they are desperately trying to make themselves feel better. And of course, the more depressed you are, the more you are a suicide risk, and it just further impairs functioning because along with depression, you get that avolition and more of the negative symptoms where you just can't get up and go and do anything. You're not able to do your ADLs. You may stop eating and drinking. You're not sleeping very well. And of course, those types of symptoms are not helpful in terms of keeping that person healthy as possible to be able to deal with their schizophrenia. Self-assessment. So we always have to think about how we feel, how we're feeling towards that person that has schizophrenia. And many times it can be very frustrating because of the anosognosia, which really means many patients really don't realize they're ill. They have, even if you tell them they have schizophrenia, back in the old days, nobody knew they had schizophrenia, so you almost couldn't blame them for not realizing they had an illness, except that they were in the hospital, but they had no idea what was wrong with them. But it really is part of the illness that they don't know that they're ill. Again, I see such a variation in that in just working with so many people with schizophrenia over the years. There are some patients that actually have quite a bit of insight that they have developed into their illness, but mostly over many years. So those people, it's a little bit easier to work with them and to provide patient teaching because they truly understand the need to be compliant with meds and try to keep their life stress-free as possible, not to abuse substances, not to be drinking a lot of caffeine, smoking, using illicit drugs, alcohol. So you can at least do some teaching and they can have some understanding of those things. Many patients get to the point where they can understand their illness to the point where they recognize if all of a sudden their hallucinations get worse or all of a sudden they feel more paranoid, then they know that they need to come into the hospital. So everybody is different as far as they're dealing with their own illness. A really good example of a patient that had a great deal of insight was a young man, probably in his late 20s, early 30s, and he had developed schizophrenia as a teenager, and so he had been dealing with it for a couple of years, and he had paranoid schizophrenia, and he basically was pretty high functioning. He had difficulty holding down a job, but he did have a girlfriend. They had 2 children, and he worked out. He was very into his own bodily health, so exercise was really important to him, eating healthy. But there were times when he just became more paranoid, and when he became more paranoid, he knew it was time to come to the hospital. Sometimes what he would do to help with his paranoia would be he would dye his hair like an outrageous shade of purple, for example, and really bright fluorescent neon purple. I'm not talking about dark, subtle, you can hardly tell it's there type of color. I'm talking about really, really bright. And he did this because he was worried, being paranoid, he was always worried about people staring at him and thinking things about him. And if his hair was purple, then he knew if people were looking at him, they were looking at him because of his hair. And so he didn't have to feel paranoid about them looking at him. So that was kind of his creative way to deal with people, staring at him. So it is caused by the illness itself. It's part of being schizophrenia for many people, and it might result in them just stopping treatment. They stop taking their meds. They don't think they have a problem. Maybe it's everyone else's problem, not theirs. And they just, and sometimes they can become so paranoid that they become suspicious of the caregivers. They're suspicious of the hospital, of the doctors, of the nurses, of their outpatient therapist. And so help really becomes very difficult. They may only come to the hospital involuntarily if they're a danger to themselves or others. They're not necessarily going to be looking for help. So sometimes nurses feel anxiety or fear, frustration, and maybe they have expectations for the treatment of that person and that person to maybe recover a little bit more than is possible, or maybe even expectations of themselves as far as being a therapeutic tool and working with patients, and that patients should respond and get better as a result of their interventions. So sometimes the nurse ends up just feeling, very, very frustrated. The other fear that we sometimes have with people that have schizophrenia is that we're really afraid that they may become violent and that they are going to hurt us. And yes, there are some patients that have schizophrenia that have become violent. There are some famous examples of people that have schizophrenia that have committed murder And, I think I mentioned a little bit ago in the other recording about a woman in San Francisco who was hearing voices and threw her 3 children into the San Francisco Bay. So yes, there are times that people with schizophrenia have violent behaviors and kill people or hurt people. However, most of the time, it has been statistically shown that people that have schizophrenia are more likely to be a victim of violence rather than a perpetrator. So it's not that it never happens that they commit acts of violence, but it's more likely that they're going to end up being a victim. Case study audience response question. So we're back to Eric that we learned about in the first video. Eric becomes anxious and says, "There are worms under my skin eating the hair follicles." How would you classify this assessment finding? Would it be a positive symptom, negative, cognitive, or a depressive symptom? I am hoping that you picked that it's a positive symptom, because he might be feeling something. He might actually be feeling worms under his skin, in which case it could be a tactile hallucination. Otherwise, if he's not feeling anything on his skin, it's probably a delusion, which is a false fixed belief. So that would be a positive symptom. All right, assessment guidelines for the person with schizophrenia. See if they have any medical problems, because again, they're not necessarily living a healthy lifestyle, taking care of themselves properly, going to regular doctor's appointments and checkups, having screening exams and getting immunizations. They're just really probably not doing those things, eating good foods, drinking appropriate amounts of fluids. They may be into, again, caffeine, nicotine, substance abuse, alcohol. So we do have to look for any kind of underlying medical problem, and then the problems that we talked about with as a result of the illness or as a result of treatment, which could be obesity, diabetes, and then everything that comes with those types of illnesses, high blood pressure, high cholesterol. Those are all somewhat side effects of some of the medications that are being used to treat their illness. So again, drug or alcohol use disorders, a full mental status exam, looking at every aspect of their appearance, mood, behavior, thought processes, thought content, if they're suicidal or homicidal, their behavior, their motor behavior. So we're really looking at the whole picture of that person. And a cognitive assessment to see if they are in reality or not. So are they with reality, or are they really so delusional that they can't perceive what's real around them? There's a nice little table at the bottom of page 200 in the Varkarolus that just kind of gives a brief outline of the assessment guidelines that we just talked about. We always want to assess for, actually it's continued up on the next page too, continued at the top of page 201. It's kind of a yellowish kind of color table. Always want to assess for hallucinations. And we don't want to make people feel that their hallucinations are real. So we always want to be careful how we ask questions about their hallucinations. So we want to say, what do you hear? Rather than saying, what are the voices telling you? Because sometimes if we say, what are the voices telling you, they may think that you think the voices are real. Some patients actually will come right out and ask you, don't you hear that voice that I'm hearing right now? Or don't you hear that baby crying or that person yelling? And it is absolutely okay to say, no, I don't hear. I understand it's very real for you, but I don't hear what you're hearing. I don't hear the baby crying right now. Because that then gives them a chance to realize that what they're hearing is not real and it's part of their illness. So there definitely are good communication techniques to learn when you're working with people that have hallucinations. Also delusions, so if they have any false ideas. Sometimes people get a little defensive if you start talking to them directly about their delusions, and especially if you call them delusions. But if you just get into a conversation about anything, what's going on in the world today, sports, what's going on the unit, what they had for breakfast, if you just kind of get a social type conversation going about something more superficial, sometimes all of a sudden you can elicit some delusional content rather than just like asking them directly for it, because sometimes I think people learn that they know what to say and what not to say, and they almost sense what we're looking for. And so asking direct questions sometimes doesn't work, but just get into a conversation about anything, and sometimes all of a sudden they'll start talking, and then you can pick up on their delusions. Always assess for that suicide risk, because that is it's such high risk. Assess the ability to ensure their personal safety and actually to take care of their own health needs. Sometimes people come into the hospital and they are so very thin because they're not eating, and perhaps they're not sleeping at night also. So those would be two things that could possibly adversely affect their health. Assess if they're taking their prescribed meds, if they're taking meds for medical conditions, and if they're taking their psychiatric meds, their symptoms impact on their functioning, on their day-to-day life. Certainly assess the family knowledge, because if the family is not knowledgeable and supportive, it's going to be really difficult for that person to follow through and to be compliant. There's such variation in what you'll find in a family's response to somebody with schizophrenia. Families could be very knowledgeable and very supportive. They could be overprotective. They could be hostile towards that person with schizophrenia. Some families just simply get burnt out because they try so hard to help that person, and that person maybe isn't accepting help or keeps going off their medications, and then they just completely give up and don't support that person any longer, to the point where maybe that person is even going to become homeless. So it is very important to assess the family. So, case study, discussion guide. The psychiatric nurse conducting Eric's assessment believes that he's also suffering from command hallucinations. Discuss what kind of questions could help affirm this. So I think we talked a little bit about this, but maybe just something just a little bit more specific. We really do want to assess if the voices are telling the patient to do something specific. And many times the patient will tell us. And it's also, I always say in clinical, it's also kind of helpful to find out if your patient is having command hallucinations, then we can have them rate them on a scale of 1 to 10. You know, how strong are they? How strongly do they feel that they're going to follow that command? And I know it sounds kind of funny, but it's always a good idea to ask if the voices are telling them to hurt anyone on the unit, and are they telling them to hurt the nurse? Because if the voices are telling the patient to hurt the nurse, we need to know about it so that we can protect ourselves. We can call security and have them be up on the unit. Perhaps if the patient is, the voices are perhaps telling the patient to kill the female nurses or the male nurses, then you can adjust the assignment accordingly. If the voices are saying to be perhaps to hurt or kill a particular patient on the unit, we can take measures to protect and make sure that everybody becomes safe. So that's a very important thing to ask. If you look on the top of page 209, there is a really excellent table that you should look at, and that is called Helping Patients Who Are Experiencing Hallucinations. So that will give you some excellent tips on how to communicate when somebody is hallucinating. Again, we always want to make sure that we don't think the voice is real, but we do want to understand what the patient is experiencing and how it's affecting them and how it might affect their behavior. We always want to make sure that the patient understands that they are safe and that we are going to help them to stay safe. Because whether they certainly believe the voice is real, and they certainly may also have some delusional ideas not based in reality. But if we say that we're going to keep them safe and we're not going to let any harm come to them, that's not providing false reassurance. That's reality, that we are going to take measures to keep that person safe. We may put them on a 1-to-1. Again, we may have security come up on the unit. We may separate them from other people, whatever helps them with their command hallucinations or their hallucinations in general. So there are some communication tips, and then there's also some things that in that table that talk about ways that patients can learn to cope themselves with hallucinations, like taking a bath, a shower, doing anything like enjoyable. So sometimes people like to listen to music, use headphones, color, those adult coloring sheets, reading out loud, whistling. There's just a ton of things that maybe patients can use that are very helpful. So it'd be good to look over that table. So some potential nursing diagnoses when people have schizophrenia. For the positive symptoms, disturbed sensory perception for sure, and that would relate to their possible hallucination experience. Risk for self-directed or other directed violence, absolutely. Again, they are more likely to be victims of violence or commit suicide, but definitely people with schizophrenia have been known to strike out or to hurt or kill people. So we do have to take that seriously, especially if they have some paranoia. They may want to kill somebody before they get killed. Impaired verbal communication, just all those different aspects of their communication that's very disordered, all the cognitive deficits and how difficult it is to understand what they're feeling and what they're thinking. Negative symptoms, some nursing diagnoses might be social isolation. And even though they may not seem to want to be around a lot of people, many times people with schizophrenia will complain about feeling lonely, about not really feeling connected with anybody, not having any friends. Maybe their family members have abandoned them. So social isolation absolutely is an issue for them. And then chronic low self-esteem. They may just really feel like a failure. They have not been able to finish college. They have not been able to hold down a job, get married, have a family. Some people do, but some people really do struggle with those issues. So they may end up just really feeling badly about themselves. So we always want to make sure that we identify our outcomes, have our goals, so patient safety, and stabilize them in the acute phase. In the second stabilization phase, help patient understand their illness and their treatment. And we may need to do a lot of repetition because of just being unable to understand that they have an illness. But that doesn't mean we should just give up. We should just continue to try to reinforce treatment. And hopefully there are many patients that actually do come to have a good understanding of their illness. Stabilize them on meds. So as far as nurses, our role is certainly to assess their response to meds, assess for side effects, and just to make sure that they actually are getting better with those target symptoms that they have. So, and again, we're trying to help them to control or cope with their symptoms. So there are lots of different coping mechanisms that people can use to try to cope with the difficulties that they have with their schizophrenia. And then in that third phase is maintenance. You want to try to prevent relapse, prevent them from getting worse again. Of course, the biggest thing with that would be to keep them on their medication and keep up with their doctor's appointments and try to live as stress-free a life as possible and a healthy lifestyle too. And we want people to be as independent as possible and at least have a satisfactory quality of life that they're happy with. So again, back to Eric. After an acute admission, discharge is being planned. What are some of the things that need to be considered? So I'm hoping that you're thinking about his living situation, his family support. Is he going to continue his medication, follow up? Is he going to go back to college right away? That might be something to consider and help him. He needs to make that decision, and just to try to help him to think about the way that he can achieve his goals and not have an overwhelming amount of stress. Certainly to stay away from drugs, alcohol, and cigarettes, things like that, things that people use to self-medicate but really aren't very helpful. And the whole gamut of healthy lifestyle and, again, trying to avoid stress as much as possible that can help him. So we're hoping he has some insurance or maybe some parents that have insurance. It sounds like from some of the other scenarios with this person that it sounds like his parents are involved and supportive. So we hope that that will continue. And money, finances, that certainly is a consideration. So lots of things to think about. And of course, Eric's safety would be first and foremost. We always want to make sure before we discharge somebody that they are not actually thinking about suicide. So Planning, again, ensure patient safety, stabilization, maintenance. Relapse prevention skills are absolutely vital so that the person knows how to, even just how to get help if they do feel that they notice some changes in themselves. So in the acute phase, psychiatric, medical, and neurological evaluation, we treat them with medication, support, education, guidance, supervision, and limit setting in the milieu, because sometimes they may be disruptive in the milieu and they may be getting into other people's rooms or getting into other people's faces. Again, the boundaries are sometimes not clear, and so we do need to set some limits. If they do have some threatening behavior or they're responding to their hallucinations or delusions, we do have to make sure that they're safe in the milieu, and that is the role of the nurse. Monitor that fluid intake if we notice that they're perhaps, even if they come in and their labs are off too, perhaps if their sodium is decreased especially, we might think that they may be having some fluid overload, drinking excessive amounts of fluids, of polydipsia. And so we might actually put them on INO if we do pick up on some of those symptoms. And again, working with aggression if they are aggressive, regularly assess for risk and take safety measures. But one of the biggest things that we can do with taking safety measures and working with somebody that has schizophrenia is just to take that very supportive stance of asking them how they feel, what's wrong, what's going on right now. If we just are so focused on controlling their behavior, and we do have to keep people safe, but it is always very helpful to at least ask what's going on right now and just validate their feelings. It sounds like you're really frustrated right now. You're really angry right now. You're upset right now. When you validate somebody's feelings, they feel valued, they feel understood, and they are less likely to act out aggressively. So, some interventions, medication again, relationships. It is very difficult, but actually very rewarding to form a therapeutic relationship with somebody that has schizophrenia. And sometimes you don't even realize that you have like a good rapport with them, but you'll notice when perhaps if you're gone a day and you come back and they were like, "Where were you? I was looking for you yesterday." And maybe you don't even think that you made an impact on them, but sometimes the value of the therapeutic relationship is far more than we even know. So, and it is very difficult sometimes just because of the communication problems. We definitely want to make sure that they are hooked up with community-based services upon discharge. In our communities in Wisconsin, we do have quite a bit of resources and outpatient services that are available for people with schizophrenia. Again, we always work teamwork and safety. We all work together for the good of the patient. Activities and groups, sometimes the patient may or may not be able to attend groups. It really depends on if they can't filter out extra stimulation, if they become angry, upset, overstimulated, just if it makes them worse, then perhaps it even makes their hallucinations worse. Then maybe we shouldn't be doing group activities, and perhaps we could just do some individual one-on-one activities with the patient. But, whatever we do, we definitely have to take the cue from the patient and make sure that they're not getting overstimulated. So, more interventions, counseling and communication techniques. Again, there's some nice tables that look at communication techniques that the nurse can use when somebody's having hallucinations, when they're having delusions, when they're having loose associations. Again, I think I talked earlier about sometimes just listen. Instead of trying to focus on the words that they're saying, the content, try to listen to the process. So in other words, like what kind of a mood are they having by the words that they're saying? Even if the words don't make sense, can you pick up on their mood? Can you pick up on a feeling state that they're having right now, or somewhat of even if it's kind of disjointed, perhaps you can pick up on an issue that they're really upset or concerned about. As far as health teaching and health promotion, I think I've talked about that a little bit too, but on page 205 in the Vark-Roloff, there's a very nice table that talks about additional nursing interventions for the person experiencing psychosis, and poor hygiene, and resistant to treatment, and cheeking of medication. So we do need to be very direct when somebody is cheeking their medications, kind of try to get their reasons for not wanting to take their medication. Maybe it's maybe we might need to switch to a medication that's either in a liquid or a fast dissolving tablet. Sometimes people are, if they don't want to take a pill every single day or a couple times a day, they actually will take an injectable form that's only every couple of weeks, and so that they don't have to worry about being compliant and taking something every day. So the other thing I like about that table is they really talk too about hygiene and how to approach that, because it's just not good nursing care to let somebody come onto the unit and then just never address their hygiene with them. You know, they may smell really bad. Other patients are going to notice it. Visitors are certainly going to notice it. And it's just not a healthy thing to do. You know, it's not healthy for our skin. And so we, you know, just really being very direct about that. And I did have a really good story about this. A student some years ago really worked with a patient a lot on his hygiene. She kept asking him, and she'd bring him towels. And sometimes it's better to not ask, or just say, ask with the expectation that they're going to achieve their shower. So in other words, bring them towels and supplies for shower, soap and shampoo, and say, are you going to take your shower at 8 o'clock or at 9 o'clock? Just, in other words, give them a choice, but kind of a structured choice. So maybe they'll say, oh, I'll take it at 9 o'clock. Well, then you're hoping that they will follow through with that, but sometimes then they still try to avoid it. It can be, you know, you can be very directive and say, here's your stuff. I will help you with your shower, or I will stand outside the door. There was a patient once who was probably about 6'4", really big, tall guy, but he was really afraid to go in the shower. He was scared. He was paranoid. So the tiny little student, who was probably 5'2", said, I'll stand outside the door while you're taking your shower, and I'll be right there the whole time. I'll talk to you through the door, and so you'll be safe. And she got him into the shower. And so I've also had other instances of students that have just kept at people and just continued to offer them and keep asking them. And finally, when they do take the shower, usually the person comes back and says, oh, thank you so much for bugging me about this so much, because I feel so much better now. So it really is an important aspect of our care to make sure people get their hygiene needs met. So that's kind of a nice little table, a purple table in the bottom of page 205. So we do have to think about medication, because that is a very important thing that we do to help people with psychotic disorders, because truly you're not going to overcome psychosis just kind of in and of itself. It's not going to just go away. So antipsychotic medications, we have the first, second, and third generation, and we do have injectable antipsychotics, and some do come in liquid form. I don't see the liquid forms being used as frequently as they were back in the olden days, because some of those are they're really hard on the stomach, and then there's only certain juices or fluids that you can mix them with. Certain medications can't be mixed with certain fluids, so you do have to be very careful. And sometimes if you don't mix it appropriately, or if you don't mix it at all in anything and give it to the person straight, sometimes nausea and vomiting is a result. So we do look to the injectables as kind of a nice alternative. They only have to take it every maybe 2 weeks, 3 weeks, 4 weeks, you know, so that's a little more acceptable sometimes to people than taking medications every day. And they do have those nice dissolvable ones too that dissolve right on the tongue, and then the person doesn't have to, they don't have the opportunity really to cheek that medication. So the first generation antipsychotics, so the very first ones to be developed, I believe is somewhere around 1950, I think, where they finally developed medication to treat people that had mental illness. And so these medications target the positive symptoms of schizophrenia. So they do not target the negative symptoms. So the more of the depression, the avolition, they can't get up and go, they can't get out of bed, they don't do their ADLs, they are kind of sad. It's kind of almost the depressive type symptoms. The first generation does not treat those. So it'll just treat like the hallucinations and the delusion and maybe some of the bizarre behaviors that they have. They're very calming. So if they're agitated and pacing, that this would help with that. So the advantage is they're very inexpensive now than the newer second generation meds. But the biggest disadvantage is that very high probability of having extrapyramidal side effects and anticholinergic side effects, tardive dyskinesia, which is more of a long-term effect, weight gain, sexual dysfunction, and endocrine disturbances. So some of those side effects, especially the extrapyramidal side effects, are very, very uncomfortable. So having an acute dystonic reaction, all of a sudden your muscles tense up, your neck can twist to the side, it can actually affect your breathing. Very, very uncomfortable. Your eyes can roll back in your head. So not very pleasant side effects for people to. Oops, I'm getting a little message about starting my computer. Nope, I don't want to restart my computer right now. Anyways, so yeah, very difficult. And the anticholinergic, the dryness, and sometimes they may become they may have some orthostatic hypotension. So, and tardive dyskinesia, do watch that video that's in the YouTube video that's in Blackboard, at least part of it, that shows you how difficult tardive dyskinesia is, and that's if it becomes permanent, then it's is a very difficult way for a person to live their life. So, second generation antipsychotics. So serotonin and dopamine they work on. Clozaril is kind of an example of this, but Clozaril is actually a medication that usually is not a first-line treatment. Clozaril is actually used as a last resort because there can be some very serious side effects with Clozaril, and most notably very severe orthostatic hypotension. It can cause 100-pound weight gain and agranulocytosis. So we've got some really serious things to to think about here. So it's not necessarily used. It's only used if the person does not respond to other antipsychotics, they will be put on Clozaril. The advantage is that it treats both positive and negative symptoms, and then the disadvantage is there's the weight gain and the risk of metabolic syndrome, so that they can also now develop diabetes, but along with that 100-pound weight gain. But the other disadvantage of the Clozaril is that you really have to have very, very careful monitoring, especially when they're first starting out with Clozaril, and very careful monitoring, and we have to check their orthostatic blood pressures. The staff has a protocol for this when they're on the inpatient unit, an hour before and an hour after the medication, every single dose. It has to be very carefully titrated until the person reaches a dose that's, acceptable and that's getting rid of their symptoms. Third generation, it's a subset really of the second generations. Abilify, brexpiprazole, Rexulti, which I have never seen given in the hospital, and Vraylar. I have seen Vraylar a couple of times. So Abilify I do see quite frequently. And actually Abilify is another medication that they can use as an adjunct to treating depression. So for some reason, when a person's on Abilify and an antipsychotic, they will have a better response to their antidepressant. So think about that as also being helpful to somebody with schizophrenia if they do have some of those depression comorbidities. So stabilizes dopamine, improves positive and negative symptoms. So at least the newer generations work on both, not just the positive symptoms. And it also helps with their cognitive function. And there's very little risk of the EPS or tardive dyskinesia. So, some potentially dangerous responses to the antipsychotics. So they may have anticholinergic toxicity, So that could be potentially life-threatening and a medical emergency. And so people that have this might have, especially older adults, if they're on multiple anticholinergic drugs, they're really at high risk. So they may have nervous system instability, delirium, altered mental status. It can make their hallucinations worse. And it may look like the patient's schizophrenia is worse, but actually it could be toxicity from the anticholinergics. So we always need to be thinking about that as a possibility. Neuroleptic malignant syndrome. It is actually pretty rare. It's only 0.2% to 1% of patients who have taken the first generation antipsychotics. But I have seen it probably twice in 38 years. So it is really quite rare. And they have like severe muscle rigidity and temperature difficulties with maintaining their temperature. They can have fluid and electrolyte imbalance. They will have reduced level of consciousness. Their fever is going to spike. They really are very seriously ill at this point, and they actually can have rhabdomyolysis happen. They can have organ failure. It's actually really quite a bit of a medical emergency. And patients with NMS should be going up to the intensive care unit. They should not be maintained on a mental health unit because that's how critically ill they have become. So again, agranulocytosis, we talked about that a little bit with Clozaril, but there are some of the other antipsychotics that can also cause agranulocytosis. So we're looking for fever, chills, sore throats, and increased susceptibility to infection. So we do want to monitor that. Some patients have a prolongation of the QT interval. And actually, I have seen this happen several times on the unit during clinical where we have a patient that has this. And it's usually Geodon. So Geodon and Seroquel are also second generation along with Clozaril. So I didn't say that before, but your book kind of lists all of them. I don't have every single medication on the PowerPoints. But Geodon, I know, has several times caused that in patients that we've worked with on clinical. So they usually would have to be changed to a different medication. So again, some very serious side effects. Liver impairment can also happen. So we're going to be looking for signs of jaundice. We're looking for yellow skin, eyes, abdominal pain, ascites, vomiting, swelling in the lower extremities, dark urine, all the things that we look for when we think about liver impairment. Advanced practice interventions with the person that has schizophrenia. Individual and group psychotherapy, education, medication, prescription and monitoring, basic health assessment, cognitive remediation. So trying to work with that person to improve their cognitive skills, and certainly family therapy would be some good interventions. And the evaluation, we always want to evaluate how we're meeting our goals and how the patient's meeting their goals. And we have to monitor regularly, adjust treatment as needed. Even if the symptoms outwardly improve, inside the patient is still recovering. So we have to set very small goals. Recovery can take months. And again, we're looking for the patient to get at whatever their new baseline is, that they probably will not be able to get back to a previous level of functioning. And of course, active ongoing communication and caring is essential. So quality improvement's important, that we are using evidence-based treatment, and we are creatively developing and incorporating treatment innovations as research becomes more available, and examine outcome data to improve patient care, adhere to updated standards of care and guidelines that incorporate the latest evidence-based practices. So probably this is a really important area for schizophrenia because when people first began to be treated for schizophrenia, prior to the advent of the Thorazine, which was the first antipsychotic discovered in about 1950, people were treated actually very cruelly. So some people were thought to be possessed by a devil, and they just didn't have an understanding of the illness at all. And some of the treatments were actually quite cruel, restraining people unnecessarily and subjecting them to ECT without any anesthesia and subjecting them to other strange treatments like insulin shock therapy and wrapping people in cold, wet sheets and weird things that we don't do today. So using research and evidence-based practice for quality improvement of the way that we care for people with schizophrenia is a very important aspect. So audience response question: which assessment finding represents a negative symptom of schizophrenia? Apathy, a delusion, a motor tic, or a hallucination? So a negative symptom, I'm hoping that you picked A for apathy. That person just, apathy, you just don't care. You're just blah. You don't really care about anything. And you just, therefore, that affects your behavior because then you won't be following through with doing things that are good self-care. So the rest of those, delusions and hallucinations for sure, are positive symptoms. A motor tic could also be a positive symptom. It really kind of depends on what they mean exactly by a motor tic. So anyways, Chapter 27, Anger, Aggression, and Violence. And again, we're kind of throwing this in with the thinking about psychotic disorders because there is definitely a risk for violence when people have psychotic disorders. But again, research has shown that more people become victims of violence rather than perpetrators. So we're still going to talk about it because anger and aggression and violence certainly are very pertinent topics for nurses. So anger is that emotional response to frustration, threat to your needs, emotional or physical, or a challenge. And aggression is the action or the behavior that results in a verbal or a physical attack. So as nurses, you might be on the receiving end of somebody's anger or possibly aggression. So it's good to learn about what are the dynamics behind it and then some ways that we can intervene so that we can avoid violent behavior. So in the hospital, violence is most frequent in psychiatric units, emergency departments, and yes, geriatric units. So if any of you have ever worked in a nursing home, hopefully you aren't surprised by seeing geriatric units. And honestly, I have actually worked, most of my career has been on a psychiatric unit. I did work in a psychiatric emergency room, which was part of the regular hospital's emergency room. So we are off in our own little corner. And I have worked geriatrics too, and actually worked geriatric neurological psych on a psych floor too, a gero neuropsych unit. And so yes, I can absolutely say that those with three areas would be very high probability that you're going to experience violence. So sometimes when people become older adults and if they have Alzheimer's then or any other type of dementia, sometimes their behavior really does change and they may still be physically very fit. And so don't underestimate an older person and the fact that you can get very badly hurt from an older adult. So some comorbidities. If people have PTSD, that is definitely something that will make them perhaps more prone to violence. There's been a couple of patients that are on the unit on 1K that we hear in their history that they have PTSD and very specific instructions on how to wake them up in the morning, like do not touch them. Don't go into their room unannounced, knock on the door, call their name from a distance. Don't go right up to them. Don't lean over them because they're going to strike out. So if we know certain things, then we should be able to keep ourselves safe. People that have substance abuse disorders, also big comorbidity with violence because if they're under the influence of that substance, or perhaps if they're withdrawing from that substance and having a really rough time, they may be more prone to violence. So we can also have violence coexist with depression, anxiety, psychosis, personality disorders, all types of different issues. So we definitely need to do our own self-assessment and understand how we feel when we work with violent patients. Are we afraid? Are we confident? Are we understanding and empathic? Or are we just challenging them and just trying to set limits and not be flexible at all. So we really do have to kind of take a look at the way that we interact with people that could tend to be violent. So to apply the nursing process, we need to do a general assessment of the patient, and usually you can pick up on a lot of cues that a person is about to become aggressive or violent. They may be frowning, they may be irritable, they may increase their demands, their voice is going to be loud, they're pacing, they're twisting their hands, all kinds of things that are warning signs. So many times a patient doesn't just blow up out of the blue. Usually there are warning signs, and if we are paying attention to those, hopefully we can head it off at the pass and not have that person go into a full violent episode, that we can actually intervene prior to that. So we always are doing an assessment and looking for different things. We want to make sure that we know the person's history, if they have a history of aggression. And I know I always give this example in clinical orientation, but I'll tell you now too, that even if they do something so simple as pick up something and throw it at someone. So an example was they used to have a big bowl of like oranges and apples right on the nurse's station on the counter. But one of the doctors was sitting in the nurse's station and the patient really wanted to be discharged. So they picked up an orange and hurled it at the doctor. So that got written into their chart. And every time that person is readmitted, it is always brought up that they threw an orange at their doctor. You might think, well, that's kind of silly, but a history of violence is a history of violence. We also hear sometimes in report that a certain person they have attacked staff in the past, or they have thrown their meal trays at someone. So anytime anyone has a history of violence, I think the staff on 1K does a really good job of keeping a log of violent incidences, and then trying to make sure that everyone is aware and knows that person's history if they are readmitted. Trauma-informed care is another concept that we have to really think carefully about, because so many people that react kind of in a violent way, in an aggressive way, many of them have had prior trauma in their own life, like they have been a victim of child abuse or neglect. So we really have to take that into consideration and consider their past experience and the role that plays in their life. And one thing that they talk about in your book on page 507, and they actually do this on 1K, is in everybody's progress notes, as one of the progress notes, they go through and they have a list of things that the patient identifies as being either helpful when they're upset or something that makes them more upset. Therefore, we can know exactly how to help that person. So some examples like from your book, they talk about maybe somebody wants someone to talk to them with a soft voice because they have them identify things that make it worse when they're upset. So if somebody is yelling at them, touching them, trying to force them to do something they don't want to do, whatever. There's lots of different things, and you'll be interested to read those when you get into your patient's charts. And then the things that help them when they're feeling upset, like if somebody talks to them calmly, if they offer them aromatherapy, maybe they want to go into a quiet room and just kind of decompress, be by themselves, listening to music. So they have people identify things so that we can provide trauma-informed care. And again, we always have to do that self-assessment because it's not very pleasant to be on the receiving end of even just anger if somebody's yelling at you or blaming you for something that you didn't do, and just being really, really difficult. It can be very, very uncomfortable to manage. So the goal is that we can at least having an understanding of the dynamics that are going on with a patient and learning some effective ways of dealing with it. Actually, this chapter really should be extremely valuable to you no matter what area of nursing you go into, because if you are in the emergency room, if you do work with older adults, or even patients can become violent on a medical unit. Women can become violent perhaps during childbirth. There's many different situations where people can become violent. Think about the person who even goes into a pain clinic and they're looking for narcotic pain medication and they don't get it. Think about their possible response. So this is really an extremely valuable chapter. Lots and lots of good information in here about learning to deal with this. So if we feel comfortable and feel like we have some tools to deal with anger and aggression effectively, we will have much more of an impact on preventing violent episodes. So case study, in the unit, Mr. Oswald's paranoia continues and he becomes agitated, threatens to assault another staff person. He tells you, "You're the only one I think I can trust." But can I? Are you going to take their side? So I wonder how we're going to respond to that one. So select the best initial intervention for Mr. Oswald at this point. Say, if you do not calm down, seclusion will be needed. Address him with simple directions and a calming voice. Help him focus by rubbing his shoulders. Offer him a dose of antipsychotic medication. So the trick is the best initial response, because possibly, one of these might be there might be two answers that are kind of okay out of these four, but one would be the best intervention initially. So I'm hoping that you picked B, addressing him with simple directions and a calming voice. So we don't want to rub his shoulders because sometimes touch sets people off. Okay, especially if they have a history of trauma, a history of abuse, we do not want to be touching people without their permission. They can see that as aggressive, even though you think you're being calming. So we have to be very careful. And honestly, 1K is a no-touch unit. We really do not offer massages, and we don't do extraneous touches except for if we have to help somebody to the bathroom or help them ambulate, take their blood pressure. Obviously, you have to touch people then, but otherwise we don't do any kind of therapeutic touch. So we wouldn't do that. Offering him a dose of antipsychotic medication, it's not a bad idea, but it's not the first thing you're going to do. First, you're going to try to calm him down. You're just going to ask him give him a simple direction like, come on over here, let's talk about it in your room or something. Try to get him out of the hallway, perhaps. You don't want to say, if you don't calm down, seclusion will be needed, because you are absolutely not even, it seems like you're not even interested in what's going on and why he's upset, and then he's going to continue to escalate. So, discussion question. A new nurse asks a coworker which patients are most likely to become aggressive or angry. So what are some risk factors that may predict violent behavior? Well, we kind of talked about a few already. So, not having their needs met, not feeling understood, having pain, not understanding what's going on, having people set limits perhaps too harshly. If something seems really unreasonable to the patient, that can be something that's going to predict violent behavior. But, having that history of having those types of actions in the past is definitely going to precipitate somebody having those in the future. And of course, if they come to you and they are under the influence of a substance, I think we probably mentioned that before. So that could certainly decrease their inhibitions and possibly cause more acting out type of behavior. So lots of things to think about. So nursing process, some nursing diagnoses would be, of course, ineffective coping. Perhaps that person doesn't have a good repertoire of coping skills, and they don't know how else to cope except by becoming angry and violent when their needs aren't being met. Stress overload, that can really happen to anybody. So just think about somebody who maybe usually copes pretty well, but they're in a situation where they absolutely are it's over their limit. They are just stressed beyond belief, and therefore they may become violent. Risk for self-directed violence, risk for other-directed violence. So sometimes people take it out on themselves so that they don't hurt other people, and some people are feeling violent towards others. So we're going to obviously identify some goals, and the implementation is all the different types of interventions that we're going to do. We always have to consider our own safety. We should try to keep ourselves safe. We absolutely have to keep the patient safe also, but we also have to try to keep ourselves safe. So hopefully you will always work in a facility where there are security officers available, because that can be very helpful in terms of the nurse perhaps stepping back and and not being in the front line. Sometimes just by seeing a security officer, a patient will immediately calm down because they'll realize that they aren't able to maybe to fight off that person. So we have to think about pharmacological interventions. It is always helpful to offer something, but usually try to work with them a little bit first. And maybe that's not the first thing you're going to say, but you definitely want to offer something as soon as you can, as soon as you start talking to them and trying to calm them down, because that could further help them. And that gives them perhaps a feeling of a little bit of control. So sometimes if people just feel like too, they have just lost control. So maybe that helplessness might be another diagnosis we could throw in there. That if you're feeling helpless and you can't get your needs met, you're frustrated, there's nothing you can do about it, about a situation, that can make people feel very, very frustrated and prone to act out. So audience response question, Mr. Oswald becomes increasingly agitated, and when you come back from break, you find out he wants to talk to you alone. Your response is to A, respect his privacy and see him alone. B, do not speak to him in private. It's time for the team to confront him calmly as a group. C, ask for him to be put in restraints first or take security staff with you. D, go to speak to him in a non-confrontational way, but ensure that there are other staff nearby for backup. So I think honestly this is a very realistic scenario. And if you look through all of the different choices that you have, this definitely would be something that would be running through your mind. What would be the best way to approach this situation? So I see this scenario as really quite realistic. So I would say that it would be, I hope that you think that it is D, that go speak to him in a non-confrontational way, but make sure there's other staff nearby for backup. So maybe the staff don't have to be right with you, and you don't want a bunch of people standing there with their arms on their hands on their hips, looking really aggressive, like they're ready for a fight, but kind of in the background, so that you can call them quickly if the situation were to escalate. If that person were to become violent, you definitely don't want to be in a situation where you are alone with a patient, and that perhaps that the patient could back you into a corner and then you can't escape from them. So we do have to think about things to always protect our safety. So the nursing process, we are going to try some health teaching and health promotion, of course, usually when that person is calm. And we are always working with other people. The whole unit needs to know if somebody has a history of violence so that everybody can take that very consistent approach. There are times when restraints or seclusion might be necessary, and that needs to be conducted in a way that is professional, and you really have to have that be the last possible resort. We should be trying every other way to diffuse a violent situation rather than just immediately putting somebody into restraints. So that should be really our last ditch effort to keep ourselves and to keep everybody else safe. So those two interventions used to be used a lot more frequently. I hardly ever see those happen anymore, but occasionally people do end up on, I really don't see seclusion used, but people do end up in restraints from time to time, but usually when all other methods are failing. So you first, of course, are going to try to interact with that person therapeutically, offer them a PRN medication, offer them any of the other comforting types of measures that they've identified in their their trauma-informed care plan. And if everything is just failing, then perhaps in order to keep them or everybody else safe, you might have to use seclusion or restraints. So, okay, well that just kind of defines what those are. So we definitely have legal requirements, and truly anytime we use restraints, it really should be because the person is in acute danger, immediate danger to themselves or somebody else. And legally, we do have to get a doctor's order. The doctor isn't always on the unit, so it's not like the doctor has to be there immediately and write the order before you can put the person in restraints, because perhaps somebody'd get hurt by the time you got a hold of the doctor. So you don't want that to happen. So it is okay to go ahead and restrain the person first, but then somebody needs to call the doctor immediately and get that order as quickly as possible. And in some states, it might even be a legal need that the doctor might even have to come in to the hospital to assess the patient within an hour of them being placed in seclusion or restraints. So it's going to vary from state to state. Documentation has to be absolutely clear, outlining the person's behavior, what you as a staff did to try to prevent the violent episode, all the interventions that you did, the patient's response to the interventions or lack of response, and then a very, very clear, thorough description of their behavior and why they were in acute danger to themselves or somebody else that brought you to the conclusion that you needed to apply a restraint. So that is very important. If anything were ever to happen with a patient suing you for being in seclusion or restraint, your documentation really needs to support that it was a dangerousness issue and that you're providing them with, you have to continue to assess them. We have to assess their skin integrity if they're in restraints. We have to offer them food and fluids, make sure that they have opportunities to go to the bathroom. So lots of different things that we have to think about when we have somebody in restraints. They should be observed one-to-one, especially if they're in any type of restraint. They should be on a one-to-one. And if they're in a locked room, it might depend on the hospital policy if they have to be one-to-one through, like, looking through a window at them, or camera monitoring if that would be adequate. So again, hospital policies, state policies, and laws are going to differ a little bit. So usually when we release somebody, we try not to release somebody just suddenly. If they're in 4-point restraints, so their ankles and their wrists, we don't want to just release them all at once, because sometimes patients do better if you kind of release one limb at a time and kind of see how they do. So you might start with a wrist, and if then they start flinging their arm around trying to hit you, well, then they're not ready to be released from restraints yet. So then you can maybe put that limb back in. Or perhaps you're going to start with an ankle and release one of their legs from restraints, and now all of a sudden if they start kicking again, you know that it's not appropriate. But if they're fine with having that one limb unrestrained, then maybe in an hour you take out another limb, and then you take out the third, and then you can release them after they're in good control. And of course you're maintaining verbal communication with them too, because you want to make sure that you are assessing them verbally, and that you can tell if they're with you, if they're cooperative, if they're calming down, if they're actually maybe even having some feelings of remorse for their behavior, or just at least understanding their behavior a little bit. So we definitely don't want to, we want to give them control, but we don't want to just take them out of the restraints suddenly. So some tips for restraints too, obviously, is that we do have to maintain all of their bodily functions. So we do have to even think about them developing pressure areas. So we have to sometimes, make sure, assess their skin, and perhaps even supply extra padding or lotion, something to keep their skin intact, food, fluids, bathroom, their mental status, because many times it's really not a very comfortable thing to be in restraints. Although honestly, some patients feel relief because they realize that they're out of control and that they can't control themselves. So they might feel safer in restraints, but there comes a time where most people really are not very happy to be in a restraint type situation. Also, the other thing that you really want to convey to somebody who's in restraints is that it's not a punishment. It truly is to keep them and to keep everybody else safe. So, case study, Mr. Oswald becomes violent and must be placed in restraint. So what questions need to be asked after this incident? So in other words, we're actually trying to think about, like, almost debriefing. Staff need to really have a debriefing episode after something like this happens, because it is really important for us to think about, did we see it coming? What are the cues and the clues that the patient gave us? Did we miss any cues? Could we have intervened differently? Because it's very helpful in that situation, but also in future situations. So, intervening in different settings. So again, patients sometimes have issues if they're in a general hospital setting, if they're in an emergency room, if they're in a pain clinic, lots of different areas that might provoke violent episodes. So again, patients with healthy coping skills who might just be completely overwhelmed, or people that just don't have good coping skills whatsoever. Inpatient psychiatric setting, and patients with cognitive deficits. So we do have to look at all of the different types of patients that we might be caring for. Again, this is just such an excellent chapter. I think that it will be useful to you in any of the areas that you end up working in. So really, your book does a great job of talking about these different issues, but just think generally about when you're a patient. Sometimes as a patient, you just feel completely out of control. You might just feel like you lose your autonomy. All these things are happening to you, and you're scared perhaps. So it's very easy to see why, being in many different types of healthcare settings, how this can really stress and overwhelm patients to the point where they may be acting violently. So, finally, Mr. Oswald is restrained. As his nurse, what's your first priority? So after he's restrained, what do you do first? Debrief the patient, ensure the patient's safety, administer a sedating medication, obtain an order from the healthcare provider. So, actually, all of these things are very important. However, the first priority would be to make sure that the patient is safe. So sometimes patients react very poorly to restraints. We always want to make sure things aren't too tight. We're not cutting off circulation. They're not able to hurt themselves or anyone else. So ensuring their safety is always the number one priority. Then probably you'd want to get that. Well, actually, I almost think you'd want to do C and D almost at the same time. Try to give them a sedating medication. They're out of control. They need something to calm down, to bring them back in control, and get that order from the doctor. So you could almost have those two things going on at about the same time. And then debriefing the patient after they're under better control and they can reflect on the situation, and they may be able to come up with some ideas on how they could have done things differently, or what they could have, maybe they could have asked for a PRN earlier, or used one of their coping skills before things got out of control. So debriefing them is really important. It's just not that absolute first priority. So another question, which patient behavior is a criterion for mechanical restraint? Screaming profanities, assaulting a staff person, refusing a medication dose, or throwing a pillow at another patient. So I'm hoping that you picked B, because that would be the thing that would be the most violent, the most dangerous. So that would be definitely a direct attack on someone. Screaming profanities, well, we want to be intervening with that person, but that's not criteria to put them in restraint. They're not a danger to themselves or others. Refusing medication, they have a right to do that. Remember in that long learning plan 1, the learning plan that never ended, we talked a lot about the rights of patients, and they have a right to refuse. Throwing a pillow, they're starting to cross the line, but actually if they're throwing a pillow, that is something that's soft. They can't actually hurt someone by throwing a pillow. So again, you do want to intervene. It's not that you're going to ignore that, but it's not criteria for restraining them. All right, I guess that's it for this learning plan. I know it's I'm talking at a blank screen right now, but I do want to point out on page 509, they talk about consideration for staff safety. And many of those things are things that we're going to review in clinical, such as not wearing dangling earrings, necklaces, scarves, things like that. Knowing the layout of the area, don't stand directly in front of the patient. nice little paragraph, and some of those things, again, we'll talk about in clinical. So I guess that's the end of Learning Plan 5.